Hello, this is Diagnosis Bona Corazza Bona, and today's topic is hematuria. Hematuria is not a disease, it's a clinical finding, and sometimes when people see that their urine a little bit reddish, it doesn't mean that it could be blood, because it could be some other substances. Also, there is some normal physical conditions when it could be microscopic hematuria. It's also normal, but in many cases the presence of blood is abnormal and requires the further investigation. Of course, there are a lot of conditions with hematuria, but we will talk just about some of them. And let's get started. Let's start with definitions. Macroscopic hematuria is the presence of blood visible to the naked eye. It's always abnormal except in menstruating women. Microscopic hematuria is the presence of blood in the urine that can be detected only by microscopic or chemical methods. Joggers and athletes engaged in a very intense physical exercise can develop transient microscopic hematuria. The time relationship of bleeding is useful because, as a general rule, hematuria occurring in the first part of the stream suggests a urethral or prostatic lesion, while terminal hematuria suggests bleeding from the bladder. Painful hematuria is suggestive of infection, urethral caruncle, calculi, or kidney infarction, while painless hematuria is commonly associated with infection, trauma, tumour, or polycystic kidneys. Pseudohematuria is a red urine caused by pigments other than red blood cells that simply stain the culture red. Causes include anthocyanin in food, it's like beetroot, berries, red-colored confectionery, porphyrins, free hemoglobin, myoglobin, or drugs. Exercise hematuria. Exercise or sport hematuria is the presence of a significant number of red cells in the urine during or immediately after heavy exercise. Urethral caruncle. This is a benign granulomatous tumor, almost exclusive to postmenopausal women. It's very tender and bleeds easily. The main symptom is hematuria. It may require cystoscopy and biopsy for diagnosis. Treatment includes warm salt baths and estrogen creams. Also, it could be obliteration by laser vaporization, cryotherapy, or cautery, and in some cases, surgical exertion. Bladder cancer. It's this condition associated with smoking. Clinical features are microhematuria, irritative symptoms like frequency, urgency, nocturia, and dysuria. Diagnosis. The most important method is cystoscopy, also urine cytology, free specimens, biopsy, imaging of upper tract, IVU, intravenous urogram, ultrasound, and CT IVU. Differential diagnosis is hemorrhagic cystitis. Treatment: cease smoking, lifestyle attention, drink ample purified water. The common carcinoma in situ is treated with intravesical BCG immunotherapy. Other treatments include surgery, such as a tumor resection plus intravesical agents, bladder resection, partial or total, and radiochemotherapy. Polycystic kidney disease is an autosomal dominant disease characterized by hematuria, hypertension, and grossly enlarged kidneys. It may be palpable, causing fullness in the upper abdomen and flank. Clinical features: family history, hematuria, hypertension, so it's a secondary hypertension, grossly enlarged kidneys, polyuria, and nocturia. Extrarenal manifestations of polycystic kidney disease include hepatic, pancreatic, and intestinal cysts, colonic diverticular, valvular heart disorders, most often mitral valve prolapse and aortic regurgitation, also abdominal wall and inguinal hernias. Aortic regurgitation results from aortic root dilation due to atrial wall changes, coronary artery aneurysm, cerebral aneurysm, aneurysm rupture in 65 to 75% of patients, usually before age 50, and it's called Berry aneurysms in the circle of Willis, and it leads to subarachnoid or cerebral hemorrhage. Diagnosis: elevations in creatinine and blood urine nitrogen, lab tests, ultrasonography, CT, MRI, genetic testing. In CT, you can find this enlarged kidney with a lot of cysts. Treatment to control hypertension, drugs to maintain electrolyte levels, to treat hematuria, analgesic plus copious oral hydration, toloptan, and surgery. Nephroblastoma or Wilms tumor is a tumor arising from the kidney, and it's a common tumor in children. Most nephroblastomas present as an asymptomatic abdominal mass. In 20 to 25% of patients could be fever, hematuria, and hypertension. Clinical findings: asymptomatic abdominal mass, fever, hematuria, hypertension. Diagnosis: renal ultrasonography, four-field radiography, CT, MRI, and treatment: tumor resection, then chemo or radiotherapy. And it could be questions like, how can you differentiate a Wilms tumor from a neuroblastoma? Because both present as a flank masses in children, and it's usually 2 years old. Neuroblastomas most commonly arise from the adrenal gland and often contain calcifications, whereas a Wilms tumor arises from the kidney and rarely calcify. Thus, imaging can usually distinguish the two conditions. Renal calculi, stones. Nephrolithiasis is often idiopathic, but there are underlying disorders that predispose to the development of kidney stones. For example, hypercalcemia due to hyperparathyroidism or malignancy, calcium stones, infection from ammonia-producing bugs like Proteus species, staphylococci, and it also could be Stockhorn calculi. It's a large stones composed of magnesium, ammonia, and phosphate, so it's called steroid, that fill the renal calyceal system. Hyperuricemia, it's uric acid stones due to gout or leukemia treatment. To prevent this complication, this patient have to be given allopurinol and intravenous hydration before leukemia chemotherapy. Cystinuria, cysturia, should be suspected if the stones is made of cystine. So, clinical features are: it could be asymptomatic or pain from the loin into the groin, and hematuria. Diagnosis: if it's a first presentation for this patient, non-contrast CT. All stones appear as dense, white objects within the urinary collecting system. Recurrent renal colic, it's ultrasound combined with X-ray. Treatment: size up to 0.5, increase water intake, analgesia. Size 0.622 centimeters, extracorporeal shockwave lithotripsy. Greater than 2 centimeters, percutaneous nephrolithotripsy. Recurrent calculi stones so patients have to take thiazide diuretics. Oral citrate is useful in patients who develop calculi stones due to low urinary citrate exertion. Allopurinol is helpful to reduce the recurrence of uric acid stones in patients who have hyperuricemia. Antiglomerular basement membrane disease is also known as Goodpasture disease. It's a cause of rapidly progressive glomerulonephritis, RPGN, is due to the presence of measurable antiglomerular basement membrane antibodies, which cause a linear immunofluorescence pattern on renal biopsy. These antibodies react and damage both the kidneys and the lungs. And you need to look for a man with hemoptysis, dyspnea, and renal failure. Clinical features: cough, dyspnea, hematuria, hemoptysis, high blood pressure, edema. Treatment with steroids and cyclophosphamide. Henoch Schonlein purpura is the most common small vessel vasculitis in children, and it is commonly preceded by a viral upper respiratory tract infection. Clinical features: vessel vasculitis of the extensor surfaces of the feet and legs, arms, and the buttocks, fever, polyarthralgia, abdominal pain, melena, proteinuria, and hematuria. The platelet count is usually normal but may be elevated. Diagnosis: blood pressure, kidney function tests. Treatment: supportive. It's just pain relievers, anti-inflammatory medicine, and just in some cases corticosteroids. Glomerulonephritis, it means kidney inflammation involving the glomeruli. It can be simply classified into nephritic syndrome and nephrotic syndrome. Nephritic syndrome, it's edema, hypertension, and hematuria. Nephrotic syndrome, it's edema, hyperalbuminemia, and proteinuria. And today we talk about nephritic syndrome with hematuria. And we will talk about two conditions: immunoglobulin A nephropathy and post-streptococcal glomerulonephritis. Immunoglobulin A nephropathy, or Berger disease, it's a hematuria after 1 to 3 days, upper respiratory tract infection or gastrointestinal infection. Diagnosis: increased serum BUN, immunoglobulin AGM. Renal biopsy will show you mesangial immunoglobulin A deposits. Treatment is blood pressure control and glucocorticoids. Post-streptococcal glomerulonephritis or acute glomerulonephritis or PCGN occurs most commonly after a streptococcal skin infection, but may also occur after pharyngitis. Patients are usually children and generally have a history of infection with a nephrogenic stain of Streptococcus species 1 to 3 weeks previously and abrupt onset of edema. It's especially periorbital edema. Hypertension, proteinuria, it's mild. It's not like for nephrogenic syndrome. Hematuria and elevated BUN and creatinine. Diagnosis is low serum C3 and CH50 levels. A positive streptozyme test confirms a recent group A streptococcal infection. Treatment is penicillin, fluid restriction, low protein, high carbohydrate, low salt diet, antihypertensive and diuretics. Thank you very much for watching this video, and next time we will talk about proteinuria.